Dr. A.Shende is working as Associate Professor in Division of Gastroenterology, Department of Medicine, MGM Medical College, Indore. He's going to speak on asymptomatic gallstones. Why not to operate?
As we see that Indian data says that around prevalence of gallstones in India is around 6.1%. 94% of these patients are asymptomatic at the time of diagnosis. Large number of gallstone patients, they remain asymptomatic throughout the life. Only 1 to 4% patients develop symptoms at the end of per year, and then subsequently 10% 5 years and 20% at the end of 20 years. So the incidence of symptomaticity goes on increasing as the years advance. Till now, there are no predictive factors which have been identified which cause a patient to become symptomatic and at what time he will become symptomatic. So if we see the WHO definition of an appropriate procedure, if the health benefits of that procedure exceed the health risks by a sufficient wide margin, then this procedure is worth performing. So, what's the aim of treatment of treating a patient who is asymptomatic? Basically prevention. We are not offering radical cure to the patient. It's prevention of complications like urinary pain and various other complications like GV carcinoma, which is again an assumption, not being proved. So we are offering prevention to the patient, not treatment. And for a prophylactic intervention, it is expected that the intervention should have 0% risk. So which is not offered by laparoscopic cholecystectomy. This controversy was sparked somewhere around a century back, when Canadian physician William Osler said that most of the gallstones they are asymptomatic, don't treat them. But on the contrary, American surgeon Sir William J. Mayo, he said in 1904 that there is no innocent gallstones. But he very cleverly said and escaped the fact that they are asymptomatic. So the point of contention, what is the point of contention where the controversy starts? It's basically when you consider dyspeptic symptoms as presentation of gallstone, then there is a umbrella under which the patients can be classified as symptomatic. But then the current opinion is that dyspepsia occurs as often in people without gallstones as in people with gallbladder stones and should therefore not be attributed specifically to gallstones. Henceforth, it's not justified to offer a prophylactic cholecystectomy to asymptomatic patients. So what are the factors which are influencing cholecystectomy in asymptomatic gallstones? It is basically the referral bias after introduction of laparoscopic cholecystectomy among general practitioners. It is the increasing patient demand nowadays कि साहब laser surgery कर दीजिए हमारी उसमें चीरा नहीं लगता है. And then subsequently the feeling of dread. If you just go onto the Google and search regarding gallstones or for that matter any disease, non-alcoholic fatty liver disease, GRD, it is all at the end. Patients are coming to our clinics, साहब वो कैंसर तो नहीं हो जाएगा लास्ट में. So it is the social media infused fear and which is subsequently seconded by some few surgeons. I would like to reiterate this point. Few surgeons, they would always infuse the fear among the minds of patients that it's a pre-malignant condition and you should get it operated. And then subsequently the coverage of surgery in medical insurance has led to a boom in elective surgeries, that is prophylactic cholecystectomy. There are possible predictors of symptomatic gallstones. There is a long list of predictors of symptomaticity, but no meta-analysis or no large cohorts have shown any positive association which of these group of subset of patients would become symptomatic and at what time they will become symptomatic. So all patients who are less than 55 years of age, females, smokers, high BMI, gallstones more than 2 cm in diameter, gallstones less than 3 mm with a patent cystic duct and non-functioning gallbladder. There are few predictors of high risk of developing gallbladder cancers as well. But then as already said, there are no large data or body of evidence to support these factors. So with this outline, I would like to proceed that the natural history of gallbladder stones, basically over a century, it's now more than a century that there is no major change in the natural history of disease, although historically and geographically there are no definite studies in India what is the actual prevalence of gallbladder stones, although the Gangetic belt is a high prevalent area for gallbladder stones. Majority of asymptomatic gallstones patients remain asymptomatic throughout their lives. Autopsy studies have shown that more than 90% of autopsied patients with gallstones died of unrelated causes. Death as an ultimate complication of asymptomatic gallstones is very, very rare. The longer the patients remain asymptomatic, the less likely they are to develop symptoms, and the majority of patients rarely develop severe, potentially life-threatening complication, and they have at least some few episodes of acute biliary pain before they come to us with complications. Bile duct injuries. There are excellent surgeons sitting out in this crowd, and with immense improvement in the learning and teaching skills, with incorporation of artificial intelligence, various indocyanine green techniques to rule out bile duct injuries, the incidence of bile duct injuries are still higher, that is to the tune of 0.6 to 1% in most of the world data. And studies have shown that bile duct injuries are not related to the learning curve of the surgeon. From very big centers, 50% of surgeons at some point of time working at high volume centers with high experience would experience bile duct injuries in their career. There is a lot of economic, physical and psychological burden of bile duct injury. The spectrum varies from simple fistulas to strictures to secondary biliary cirrhosis to subsequently liver failure, transplant and death. The mortality rates are to the tune of 4 to 9%, which are not acceptable for a prophylactic cholecystectomy. Bile duct injury after laparoscopic cholecystectomy is the most common claim. There is a study from United Kingdom that NHS litigation authority, they are accepting the highest number of claims following bile duct injuries, and the highest proportion of claims and largest sums have been paid for these bile duct injuries. So I'll touch upon a very interesting aspect. I went to the literature and I wanted to compare a prophylactic surgery. I think prophylactic mastectomy is one of the best justified surgery in medical science. Prophylactic cholecystectomy is not. Lifetime risk of cancer for a lady who is BRCA1 gene mutation positive, she has a risk of around 80 to 90%. The 20 years cumulative risk of cancer is very, very high for cholecystectomy, for mastectomy, as compared to only 0.1 to 1.5% for cholecystectomy. The quality of life adjusted years are very, very low in prophylactic cholecystectomy. The cost of surveillance of breast cancer would be somewhere around $35,000, and for a prophylactic mastectomy it is $36,000. So it's very imperative to go for a prophylactic mastectomy. On the contrary, spending $15,000, which comes to somewhere around 25 lakhs rupees of Indian currency, is not justified. There are various changes in the gut microbiome following cholecystectomy, and various studies have shown that there is decreased gut microbiota diversity in patients who have cholecystectomy. There is reduced Faecalibacterium bacteria, which is a beneficial bacteria. There is decreased short chain fatty acid production, which subsequently leads to a pro-inflammatory microbiome, and there is increased incidence of opportunistic pathogens. A very interesting study by Zhang et al., which involved 10 cohorts with more than 5 lakhs patients in this study. They have shown that there is increased incidence of colorectal cancer post-cholecystectomy because of DNA damage and increased gene mutagenicity. There is increased lipopolysaccharide synthesis, and they found that hepatic metastasis was more common in post-cholecystectomy syndrome with colorectal cancer. There are huge financial consequences of healthcare system as well. Studies have shown that private health insurance played a key factor in the overwhelming healthcare expenditure in various studies. A study from America has shown that there was almost a 10% increase in elective surgeries post expansion and inclusion of laparoscopic cholecystectomy prophylactically. Post cholecystectomy syndrome, which again has a big umbrella under it, has a prevalence of around 47%. There are varied presentations, and it accounts for around 35% of PCS. I would be with my surgeon colleagues, just 1 minute, with my surgeon colleagues, that they have very difficult times in doing a very, very difficult inflamed scarred gallbladder, but no meta-analysis has yet proven this assumption. There are various absolute indications for prophylactic cholecystectomy. Professor Loya, who was my teacher, he used to tell us porcelain gallbladder is an absolute indication for, but there are only very limited now indications for an absolute prophylactic cholecystectomy. They are sickle cell disease, hereditary spherocytosis, heart transplant patient, even non-hepatic transplants, they are not candidates for prophylactic cholecystectomy. Individuals who are going for a space expedition or remote expeditions, they are neuroendocrine tumors and patients on somatostatin analogs. So there are various relative indications I would like to skip. Again, I would like to skip. All the parent bodies and scientific societies, NIH, EASL, Cochrane database, SAGES, SAT, and even ISPBA, they also don't say that you should do prophylactic cholecystectomy. There are certain justified indications for discussion regarding laparoscopic cholecystectomy, which I also feel from depth of my heart. Multiple small gallbladder stones less than 1 centimeter, solitarily large gallstones more than 1 centimeter, gallbladder sludge occupying more than 50% of the gallbladder volume, and a fit older patient with high stone burden to prevent further anesthesia complications. So I would like to conclude, medical community should not make a blanket policy of advising cholecystectomy to every patient of gallstones in high risk and emotionally justified profiles. I can discuss some emotionally justified profiles on this forum if time permits. A careful discussion with these patients regarding cholecystectomy should be offered to minimize the likelihood of morbidity and complications. Disclosure of material information is essential for a reasonable patient to make an informed choice of prophylactic cholecystectomy. We are living in an era of litigations, so we should stick to guidelines to be safe in the court of law. Thank you so much.
Ajit, now you can come on the stage so we can have some debatable questions. I have a feeling that this question, asymptomatic gallstones, will always remain. But Atul has narrowed down, and he has said that yes, there is a subgroup where asymptomatic gallstones should be operated. That is one. So now we know that some of the asymptomatic gallstones should be operated. Second, as Ajit said, I feel, who is silent? That should be very carefully asked in the history. Is it the patient? Is it a stone? And we should also know the natural history of gallstones, why gallstones form. It is not only super saturation of bile, but also reduced function of the gallbladder, and once a stone forms, in some time the gallbladder stops functioning. So now you have a scenario where you have a proven pathology of a non-functioning organ which you know. And on the other hand, we also know in our clinical practice that we do a lot of invasive diagnostic procedures just based on the history where we don't know there is any pathology. To give you an example, IBS-like symptom when we do colonoscopy, which also has got some complication rate. So I think it has to be very carefully debated and thought by the physician, and physician should also give the data to the patient who seems to be having a asymptomatic gallstone, that what is the probability of getting complication and what is the probability of developing a cancer. Here in India we don't, but in Chile we do asymptomatic gallstones, all gallbladders come out, because there this cancer rate is more than 12%. In India it's 1 to 2%. So I think this is what should be, both of you have put forward in your slides. You want to say something else, or if, yeah?
I think at the outset, very good talk from both of you, but I think biggest war of the world have been fought when two rights were confronting each other. Regarding gallstone, I think my take is that it should be decided by the patient, because it is asymptomatic. But Dr. Atul, I would like to point one thing, that even if you are not operating, the patient is having a risk. And it's a substantial risk, maybe less than 5% of complications still is having. In surgery, the risk of CVD injury is less than 1% in expert hands. So both ways you are having that risk. So my personal will be that I will be more inclined towards getting surgery done, because there are a lot of patients, we also see that patient comes with GB malignancy, and if we take the history, she is knowing about her gallstones for the last 5 years, but because they were asymptomatic, she didn't get operated. So I think that is the thing to be seen. And even legally, I think sir is very right that when the patient comes to my practices, that I always tell all the statistical data to the patient so that he or she should be aware about the potential complications.
You are absolutely right. I also follow the same practice in my clinical practice, but then you need to be backed up by, suppose even a single case goes wrong and then that patient goes to the court of law, you are not backed by evidence, and that's the biggest thing now we are facing in our clinical practice. We are living in the era of litigation. You have strong body of evidence. There is a very small margin between asymptomaticity and symptomaticity and asymptomaticity. So it's basically matter of semantics when to, like just few days back, a young lady IT engineer, she came to my clinic and she said me, sir मेरी माताजी pancreatitis से उनकी death हो गई थी, मेरी अभी शादी हुई है, I want to become pregnant and I also have got multiple 6 mm stones. So, and she has no symptoms, she has just got married. So these are certain issues wherein you are speechless, there are no guidelines, these are grey areas, you cannot speak and to tell what to do.
Sir, great debate, but I have a question for Dr. Shende sir. As Vashne sir also pointed out that even in IBS, colonoscopy has its own problems. I will go one step ahead because we all know that polyps, colonic polyps, they are pre-malignant conditions, and we know that they causes 5 to 10% more malignancy. They will convert into malignancy, and there is a very clear-cut surveillance program that above 50 years everybody has to go for colonoscopy. We know that colonoscopy in general population will have some complication, and we know that colorectal cancer can be decreased if we do polypectomy. Now if I want to translate this data into this condition, because it is also having the same situation that it is asymptomatic gallstone, but we know that inflammation and ultimately will lead more incidence of carcinoma gallbladder, and we know that carcinoma gallbladder is very bad. You put it in another way that a young lady came and it is very difficult to define, but you know, patients are coming to us with fatty liver and they are asking, you have not treated me because it can cause cirrhosis and cancer. Now this is again a problem. And regarding natural history and cost and benefit ratio, we always try to translate from Western data. But in India, we know there is some different. Lean fatty liver we are saying, and we say in Ganges belt that with gallstones there are high incidence of cancer. And we all know that, although you said that symptom decreases with time, but we all know that malignancy increases with time.
Yeah, you are right, Dr. Arvind, but then these surveillance programs which are run in America for surveillance of colorectal cancer, they also have big cost issues behind them. And then the surveillance systems for gallbladder cancer monitoring in case of polyps of gallbladder, they are also not very, means they are not justified, and no study has shown a very strong association like there is a GB-RAD system. But then the cost which goes into surveillance of these polyps or for that stones is, you are doing a sonography for 1,200 rupees in India, you are doing a colonoscopy for 8,000 rupees or 5,000 rupees somewhere in India, but then they are paying 2,40,000 in America. Everybody is insured, so they are paying hefty sums. So at some point of time I feel that the surveillance programs, they are also to be minimized and can be standardized.
No, as far as this issue is concerned of colorectal cancer, let me tell you, the incidence of polyps is certainly much more higher in Western societies compared to our place. There the incidence of CRC is also very high. Our colorectal cancers probably follow a different kind of a pathway. Now the thing is, management of colorectal cancer has now become almost molecular, and a precision medicine is now coming into this. Everyone knows now it's not a simple adenocarcinoma sequence in every patient. There are multiple other pathways also, and different kind of colorectal cancers can have different prognostic, different kinds of prognosis depending on the molecular pathogenesis. That is besides the point, but this thing. And so that is one of the reasons why surveillance program for colorectal cancer is there in America. Now, so they have reduced for colonoscopy, it's now almost that everyone should have it after age of 45 years. They have reduced it by 5 years again, the current guideline. Now, as far as this issue, CEO gallbladder is concerned, we have been discussing, but what we have been experiencing in practice, all of us are there. It's just like a dictum that if you go to a barber shop, you will have a haircut. You go to a surgeon, he will advise surgery. Most important thing is, as Dr. Vashne has mentioned, a careful history is very, very important. Is it really truly asymptomatic gallstone? many of the patients may have very subtle kinds of biliary colics. Not only that, many of these patients have features of functional dysplasia which is not connected to this particular problem. What is happening in clinical practice is it's a kind of a procrastinian attitude. I think all of you know who Procrustes was. Just to tell you from a Greek mythology, he was a giant who used to sit by a roadside keeping a rectangular block with him. Any human being going there, he would put him on the block, see this thing. If the person was taller, he would cut his limbs. If the person was shorter, he would stretch him so that he fits into the block. That means if you want to do a surgery, all the symptoms you must try to attribute it to the gallstones, which may or may not be there. So that is very important in clinical practice. Third thing is there are certain softer indications. There is one area which I certainly would like to say. What about the diabetics who are really uncontrolled and have gallstones? There has been a lot of debate on whether these patients should be offered a prophylactic cholecystectomy or not, because the problems with emergency surgery, etc., and complications are higher in those particular situations. You have also pointed out in one of the slides that you did not show that there are certain gray areas and diabetic population is one.
Yes.
So, due to shortage of time, we would like to close this session. And this debate, until it ends, I think asymptomatic gallstones, where the main concern is a bile duct injury and complication, so these should be sent to experienced surgeons so that it doesn't happen. Thank you.
But even experienced surgeons, they have got complication rate of 0.5%.